Hello everyone, my name is Ala Sayed. I'm a fourth year medical student at King Saud bin Abdulaziz University for Health Sciences. And today I'm going to talk to you about strokes. Now, I would recommend you watch our other video about the blood supply of the brain so you could understand this video better. This is an outline for our talk today. We're basically going to talk about some epidemiology, some definitions, and then the classification or types of strokes, and eventually some risk factors of strokes. Now let's start with some epidemiology. The annual incidence in the UK varies between 150 to 200 cases per 100,000. Now, with a prevalence of 600 cases per 100,000, of which 1/3 of the patients are actually severely disabled, and approximately 20% of stroke patients will actually die within the upcoming month. Not only that, but the incident rates actually increase with advancing age, and it is actually approximated that 20 to 25% of individuals above 45 will actually have a stroke. Can you even imagine that in developed countries, strokes actually rank third as cause of death after ischemic heart disease and cancer? Now, from all strokes, approximately 1/3 of those strokes are fatal. Now, stroke is characterized by rapid appearance, usually over minutes, of focal neurological deficit. So this is a very important, actually, characteristic of stroke. So over minutes, the patient suddenly loses sensation, or the patient loses the ability to move. And this is very important to differentiate stroke between other kinds of etiologies giving the same kind of symptoms. Provided there is a clear history of rapid onset focal deficit, chances of brain lesion being anything other than vascular is only 5% or less. Now let's start with some definitions. Now, what is a transient ischemic attack? So basically it's a stroke in which the symptoms resolve within 24 hours or actually less. Now, what is a stroke? A stroke is actually when the symptoms resolve within more than 24 hours. Now, what is a progressive stroke? It's also called stroke in evolution. So it basically means that the patient started having symptoms, and then after a period or after a while, the symptoms actually worsened since they first began. So the patient wasn't able to move a part. Now he's unable to move a bigger part, or he has more symptoms, more sensory symptoms or something. Now, what is a completed stroke? Now, a completed stroke is actually when the focal neurological deficits persist, but they're not progressing. So like a patient had a stroke 1 month ago, he cannot move his legs, and up till now, he cannot move his legs, although the stroke was 1 month ago. So this is what we call a completed stroke. They're not progressing, but the deficits are still there. So transient ischemic attack, also called TIA, stroke, progressive stroke, and a completed stroke. Moving towards our third topic for today, which is classification of strokes. Now, strokes are actually classified according to the etiology or the mechanism in which the stroke actually evolved. Now, the classification is to ischemic strokes and hemorrhagic strokes. Now, ischemic strokes comprise about 80% of all strokes, and hemorrhagic strokes comprise about 20%. Now, ischemic strokes are actually subdivided into thrombotic, embolic, and generalized reduction in cerebral flow. So basically, those are just mechanisms, different mechanisms in which ischemic stroke can happen. And hemorrhagic stroke is actually divided into intracerebral hemorrhage and subarachnoid hemorrhage. Now, in the upcoming slides, we will actually discuss each type at a time and in more details. So again, ischemic strokes are divided into thrombotic, embolic, and generalized reduction in cerebral blood flow. We will first discuss the thrombotic. Thrombotic infarct is the most common type of ischemic infarct. Now, depending on the diameter of the vessel, you have different mechanisms in which the infarct might happen. And that's why thrombotic infarct is actually further subdivided into large vessel infarct and small vessel, or also called penetrating vessel infarct. Starting by large vessel infarcts, what actually are large vessels? So based on the last video, large vessels are actually branches of the carotid and the vertebral arteries. So you include the carotid, vertebral arteries and their main branches like the anterior cerebral, middle, posterior cerebral, and also the basilar artery. So those arteries are actually what we call large vessels. Now, what exactly does happen in those large vessels? Now, actually, the thrombus will form by a process called atherosclerosis. Now, basically, what you have here is a blood vessel. Now, in a patient with hypertension and high cholesterol, what happens is that the blood vessel's lumen, as you can see here, here's a normal lumen here, and this one is diseased. Now, the blood vessel lumen is actually prone to get injured, and when it's injured, you form something called a plaque. Now, the plaque actually narrows the vessel down, as you can see here, and with subsequent hypertension and subsequent blood flow within that vessel, the actually plaque is even more prone to rupture. And when the plaque ruptures, it actually is more prone to develop a clot because platelets will come, aggregate there, and form a clot on the vessel. Now, this process of atherosclerosis will eventually end up, as we said, with a blood clot. As you can see here, when the blood clot forms in a large vessel, that vessel is occluded by the clot, and eventually you will end up with an infarction, or in other words, the blood won't go beyond that clot into the brain. Now, the large vessels are actually divided into extracranial vessels and intracranial. Now, I just want you to know the most common sites of atherosclerosis within those vessels. Now, in the extracranial vessels, the most common site is actually the bifurcation of the carotid arteries. And in the intracranial vessels, the most common site is at the origin of the middle cerebral artery. Now, small vessel infarct is also called lacunar infarct. Now, before we start talking about the infarct, let's start talking about those small vessels. Now, the small vessels are actually also called penetrating vessels. Now, those vessels are actually small vessels supplying the deep structures in the brain, like basal ganglia, internal capsule, and the pons. Now, what exactly happens to those vessels so you could end up with an infarction? The first process is actually microatheroma, as you can see here. So it's basically atherosclerosis, but in a smaller vessel, and that's why it's called microatheroma. So basically, it's atherosclerotic changes within the vessel. You end up with a clot formation and blockage of that vessel and an infarct. The second process is actually called lipohyalunosis. To understand that process more, you need to recall something. Now, the small vessels, or the perforating or the penetrating arteries or vessels, are actually branches of much bigger arteries. And those arteries, like the middle cerebral artery, are actually arteries with high blood pressure. And as they divide into those smaller vessels, that high blood pressure is actually transmitted to that small blood vessel. So that blood vessel becomes more prone to injury. And that happens with patients with chronic untreated hypertension, as you can see here. When the patient has chronic untreated hypertension, so there's hypertension for a long period, the small vessels are subjected to blood pressure for a really long period. So the vessel actually begins to accumulate damage. Imagine this as a normal blood vessel, and here's the lumen. So in lipohyalunosis, actually, the whole wall of the blood vessel starts to accumulate damage. You can even eventually end up with scar formation. So the vessel wall will actually thicken, and you'll even have some foam cell or macrophages macrophages depositing in the form of foam cells inside the vessel becomes abnormal, as you can see here. Actually, this is a picture of lipohyalunosis. So as you can see here, the vessel is abnormal, the lumen is really constricted, and eventually you might end up with some small clots, and the end result is actually blockage of that vessel. When that vessel is actually blocked, the perfusion to that area will decrease and you will end up with a lacunar infarct. Another risk factor for lipohyalunosis is actually diabetes. Now, the most common mechanism of a lacunar infarct is actually lipohyalunosis, followed by microatheroma. And the third most common mechanism involved in lacunar infarcts are actually thought to be by embolisms, and we will see that in the upcoming slides. Now, the third mechanism, as we mentioned, an embolism. The fourth mechanism is actually by microaneurysms. Now, what is an aneurysm? An aneurysm is actually an abnormal dilation of the blood vessel wall because of structural weaknesses. Now, in those vessels, you might get a micro or a small aneurysm, and this aneurysm or weakness might bleed, giving you actually a hemorrhagic stroke. And we will mention hemorrhagic strokes with more detail in the upcoming slides. Now, occlusion of those penetrating arteries or small arteries will actually give you subcortical infarcts. They're usually less than 1.5 centimeters in diameter, and they're called lacunes. Now, what does this word actually mean? From the Greek, it actually means a cavity, a cavitation, or actually, more precisely, it means lakes. So a cavity or a depression, and that's the appearance of those strokes. Now, the most common lacunar syndromes are the following. 1, pure motor hemiparesis, pure sensory, and ataxic hemiparesis and dysarthria with a clumsy hand. Now, as you can notice here, they do not come together. They actually, each syndrome comes like alone, separately. So the symptoms of this kind of stroke are actually subtle. So the patient will only have motor symptoms, or the patient will have sensory symptoms, but they don't have both together like other types of strokes. And this is actually a hint to lacunar strokes. Now that we're done with the thrombotic kind of infarcts, we will move to the second type of ischemic strokes, which is an embolic stroke. Moving to embolic strokes. Now, what is an embolism? An embolism is actually a clot or a thrombus that formed somewhere else than the place it is within right now. So if it's in the middle cerebral artery, it did not originate from there, or the clot did not happen there. Instead, it came from another artery. And this is what we call an embolism. Okay, now they are divided according to their site into cardiac or aortic emboli and infectious and paradoxical emboli. Now, let's take each one. Now, moving to cardiac and aortic emboli, there are two words you can see here, thromboemboli and atheroemboli. So let's explain the difference between both of them. This is an artery and this is an artery. You have a plaque here and you have a plaque here, caused by atherosclerosis. Now, in one vessel, you had a clot formation here, and the clot itself actually dislodged and went into another vessel. And this is what we called a thromboemboli. So a thrombus, a clot, moved away. Now, in the other case, which is an atheroemboli, it's mostly part of the plaque that actually moved and blocked another vessel. Now, let's take the thromboemboli. Thromboemboli can happen in atrial fibrillation and ventricular hypokinesis. So let's explain this in the picture. Now, if let's imagine that the atria itself is not contracting that much, like in atrial fibrillation. So it's just fibrillating. So the walls are not actually contracting too strongly to move all the blood within the atria. So some blood within the atria, near actually the appendages of the atria itself, will actually become static. It won't move. So a clot is prone to form in that area. And if that clot dislodges from the atria and goes to the ventricle, through the ventricle to aortic arch, it might end up within any of the cranial vasculature. And this is what happens in atrial fibrillation. The same thing happens in ventricular hypokinesis, like in heart failure. So the ventricle is not contracting that well. The ventricle is actually also dilated, and then the clot forms within the ventricle. The clot is pushed through the vessels into the cranial vasculature, and you get an embolism. Now, prosthetic valves might actually induce clot formation, especially if they're mechanic valves. Also, in merantic endocarditis, it's actually a non-bacterial endocarditis. What happens here is that you end up with a vegetation. Now, what is a vegetation? It's basically a ball of stuff. Now, in non-bacterial endocarditis or merantic endocarditis, it's actually the vegetation is made up of fibrin, platelets, so they form within the heart and usually at the leaflets of the valves, and then they are pushed from the ventricles, they dislodge from the leaflets and move to the cranial cavity. Now, in atheroemboli, so the aortic arch atherosclerosis, you have atherosclerosis, part of the plaque just dislodges and moves towards the cranial cavity. Now, in infectious emboli or bacterial endocarditis, what actually happens is a bit similar to the other type of endocarditis. Now, in bacterial endocarditis, you have bacteria or a microorganism moving within the blood. Now, as it moves within the blood, it actually meets the leaflets in the heart. On the leaflets of the heart, especially in the left side of the heart, there are actually a lot of nutrients. It's a really rich environment with oxygen, nutrients. They get stuck on the leaflets. And because of the nutrients and oxygen, they actually grow and grow more bigger, forming a vegetation. And that vegetation, like the other one, might dislodge and go to the cranial cavity. Now, the last thing is the paradoxical emboli. Now, basically, it's an embolism coming from DVT. Now, you actually remember that DVT gives you pulmonary embolism, and this kind of makes sense. So imagine a clot coming from the leg. This is a leg of a patient. So this is a clot coming from the leg of the patient. It would go into the right side of the heart, so into the right atrium, and from the right atrium, left atrium, and then into the pulmonary circulation, and it will actually end up in the lung, giving you PE. But in those patients with paradoxical emboli, they have a patent foramen ovale. So it's a foramen between the atria. So the clot, instead of moving towards the right ventricle, it actually moves towards the left side. And from the left side, it can go into the cranial cavity. The third type of ischemic strokes is generalized reduction in cerebral blood flow. The generalized reduction in cerebral blood flow will give you a watershed infarct or a border zone infarct. Now, what are watershed zones or border zones? Actually, they are areas in which the brain actually gets the amount of blood supply it needs barely at normal circumstances. So it gets the amount of blood, but if something goes wrong, they immediately get affected. So let's explain it even more. We mentioned in the previous video, the blood supply of the brain actually comes in this way, from the middle. You get some blood supply, and also laterally you get some blood supply. Now, the areas where those two distributions of blood supply meet is called a watershed zone. And this watershed zone barely gets its blood supply at normal circumstances, so it gets enough blood supply normally. Now, if something goes wrong, imagine the blood going to the whole brain is getting more. So they are actually even more prone to get ischemic because they were barely getting the blood supply. Imagine now that the blood supply is even less, they get ischemic really fast. Now, what are watershed zones? Again, they are actually between the anterior cerebral and the middle cerebral arteries, and also between the posterior cerebral and the middle cerebral arteries. They're actually between not the main branches, but the deeper small branches of those arteries. Now, the causes of a reduction in cerebral blood flow include hemodynamic shock, cardiac arrhythmias, septicemia, and narcotic overdose. Narcotic overdose, you actually get systemic hypotension, so yeah, reduction in blood supply. Now that we talked about the types of strokes, let's talk about basic pathophysiology. Now, what happens normally when you get a clot in any vessel? Imagine the middle cerebral artery. Actually, the circle of Willis or the other blood vessels will try to compensate through other channels to give blood to that area that is not getting that enough blood supply. Now, this is a homeostatic mechanism. Now, when that homeostatic mechanism actually fails, you begin to have reduction in cerebral blood flow. So when the cerebral blood flow actually goes beyond 50, what happens is that as the neurons are starving, they start to demand more oxygen. So as soon as they find oxygen, they're like, dude, oxygen, take it now. So they increase their oxygen extraction from the blood itself. Now, after that, if it reaches 20, you have failure of electrical function. What does that mean? That means that neurons will actually go into sleep mode. They will go into hibernation. So they're like your computer. It's not working. The screen is not working right now. So it just takes a sleep. Okay, so nothing within the neuron is actually working. So the neuron is like taking a break. So it's not doing its job. So if you imagine that the neuron is not doing its job, you begin to have the symptoms. You begin to have a loss of sensation. You cannot move. And that actually will continue to happen as long as the blood supply is still reduced. And if the blood flow actually goes even lower, below 10, here you will actually get failure of ionic pumps. And the cells begin to die. Okay, continuation, TIA. Now, what exactly is TIA? Now, remember we mentioned if those neurons go into sleep, they stop working and you start having the symptoms. Now in TIA, actually, they go into sleep, but they do not reach the state in which they die. So the blood supply will be restored again within less than 24 hours, and that's why the symptoms will actually disappear. So when the blood supply goes up again, the neurons regain their function and you lose the symptoms you've had. Here we will actually explain what will happen when cells become more ischemic and actually die. So let's start from the beginning. When you have less blood supply, less blood, this means less oxygen, less ATP, right? So when you have less ATP, actually a pump on the side of the neuron will actually stop working. Now, normally that pump actually pushes sodium outside and potassium inside the cell. Now that it stops working, sodium stays in and potassium does not go out. Now, the thing is, when sodium stays in, actually water always follows, so you end up with cellular swelling or edema, and this edema is actually called cytotoxic. Now, with the deactivation of this pump, you get depolarization of the neuron itself. Now, depolarization will actually cause the entry of calcium within the nerve ending of the neuron. Now, the nerve ending will actually release the neurotransmitter glutamate, which will activate two channels. One will allow the entry of sodium and the other the calcium. And when sodium goes in, it adds to the edema, so you get more swelling. And when calcium goes in, it activates actually proteases. Proteases are enzymes that will start chopping off proteins, meaning it will start chopping off the neuron itself and killing it. Now, the process of death with the neurons will actually be exacerbated by the fact that with less blood and less ATP, the neuron will actually start anaerobic metabolism. So more lactic acid is formed and the pH goes down and the cells die even more and faster. Okay, in this picture, you actually see that here's the infarct. And as you can see in MRI, it's even more clear that you have edema or swelling. And how did I know that? Can you see the ventricle? It's actually like squashed by the edema and it's pushed aside. As you can see here, this is because of the edema within the neuron. And actually, the edema after a stroke increases within the subsequent week, and that's why sometimes, even though the stroke is resolving, but because the edema is actually staying there, the patient might get like worsening of the symptoms. The second type of strokes are actually hemorrhagic strokes, which comprise 20% of all strokes. They are divided into intracerebral hemorrhage and subarachnoid hemorrhage. Intracerebral hemorrhage is actually bleeding within the brain parenchyma. The causes include traumatic causes and non-traumatic causes. In non-traumatic causes, chronic hypertension is very important. Also, vascular malformations like arteriovenous malformation, we will explain that in a minute, and cavernous hemangiomas. Also, bleeding disorders and anticoagulation therapy and amyloid and angiopathy. Now, an amyloid angiopathy, actually a protein called amyloid start depositing into the blood vessels, and the blood vessels become more weaker and they are prone to bleed. Okay, we'll talk about arteriovenous malformation, but let's talk first about the normal anatomy of arteries. Now, as you can see here is an artery. It breaks off into arterioles, smaller arterioles, and then the arterioles break off into smaller and smaller capillaries. Now, the benefit of all this is that when the artery with a high blood pressure breaks off into smaller and smaller capillaries and arterioles, the pressure itself, as the artery is branching into more branches, is actually divided on all of these branches. So when you divide the pressure on like 5 branches, the pressure eventually becomes less within the branches. Okay, and this is like a protection to the capillaries, and they do not get injured that easily because of this. Now, in arteriovenous malformation, what happens is that you have a feeding artery, a single feeding artery, and then it just breaks off into this network or nest of capillaries and or arterioles, without giving you that branching kind of architecture. And then eventually they give you this nest, or also called a nidus, okay, and eventually one single vein or draining vein will drain the whole kind of structure. Not like here, as you can see, small venules joining and then bigger branches, and eventually you get the vein. Here, no, it's only one single vein draining the whole structure. Now, the problem with all of this is that, as you can imagine, the high blood pressure is actually transmitted to those arterioles here, and those arterioles will become more prone to damage, and they might bleed. So as you can see in the other picture, the blood comes here and it starts accumulating within this nidus or nest, and this nest becomes damaged, it becomes distended, and eventually it cannot take that much more of blood, and it actually ruptures and bleeds, and it gives you a hematoma. As you can see here, it's becoming bigger and bigger, and eventually it will give you a hematoma and bleed. It will bleed within the brain substance itself. Now, as you can imagine, a hematoma or like a bleeding here, okay? Now, I'm a neuron passing from here to here. What will happen to me? As the bleeding is moving, it will just come and cut me off. So this is how the intracerebral hemorrhage actually damages the neurons. Now, for the other type of hemorrhagic stroke, we're going to subarachnoid hemorrhage. Subarachnoid hemorrhage, what is it? It's actually bleeding into the subarachnoid space. Now, as you can see, I put a note here. Most subarachnoid hemorrhages are actually caused by spontaneous bleeding rather than traumatic causes. Now, causes include, in most cases, they include ruptured intracranial aneurysm, and about 85% of cases. And this aneurysm is actually called a saccular aneurysm or a berry aneurysm. And here, as you can see other kind of causes. Okay, risk factors for subarachnoid hemorrhage: family history and genetic factors, smoking, hypertension. Now, the symptoms of subarachnoid hemorrhage include severe abrupt onset headache. The thing is, the headache is actually acute. Not only that, it's actually very, 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 very severe. Some sentences to describe it are thunderclap headache, sudden blow to the head, worst headache of my life. So if you have a patient coming to you saying, this is the worst headache of my life, okay, always think subarachnoid hemorrhage. Now, let's talk about saccular or bearing aneurysm. This is the aneurysm I just mentioned as the main cause of subarachnoid hemorrhage. Now, the most common site of this aneurysm is actually at the anterior communicating artery, and especially between its junction with the anterior cerebral artery. Now, risk factors for bearing aneurysms include smoking, hypertension, adult polyposis kidney disease, Marfan syndrome, and Ehlers-Danlos syndrome. Now, the thing about those three is that those patients have abnormal collagen, so their blood vessels are actually not normal and more prone to bleed. Here's a picture of an aneurysm. As you can see, the artery is actually dilated, and the bigger the artery or the bigger the aneurysm, the more prone it is to bleed. And when it bleeds, as you can see here, it bleeds within the subarachnoid space. So as you can see, it can bleed within the whole subarachnoid space here, and that's why sometimes it's actually subarachnoid hemorrhages are called surface hemorrhages. So what if you bled into the subarachnoid space? Why does that cause you a stroke? The blood itself that goes into the subarachnoid space is what causes a problem. Now, if the blood leaks into the parenchyma of the brain, it can cause you an infarction. Now, the other thing, the blood itself, when it leaks out, it actually goes on other blood vessels and it causes like severe vasospasm. When those arteries contract, actually, you have contraction of the arteries, and if you can imagine some brain tissue here, it looks like noodles, but okay. When you have the vasospasm and arteries are also contracting, what happens is that you have reduction of the blood flow to the area under the capillaries or under those vessels. So that's why you end up with an infarcted area, an area without blood supply, and that area actually dies. Okay, we will now move to risk factors of strokes in general. It's not for a specific type. So we'll divide them into two, non-modifiable risk factors and modifiable. So non-modifiable include age, which is actually the strongest risk factor for strokes, but you cannot do anything about it. The second thing is family history of MI or a stroke, male gender, ethnicity like African American, Hispanic, and Asian. Now the modifiable are actually into two words. So live the way a coach should. So coach, you take the whole word, and should, you just take the first two letters and the last two letters, and you actually add a D. So okay, coach, so coronary artery disease, obesity, atrial fibrillation, carotid stenosis, hypercholesteremia. And should include smoking, hypertension, diabetes, drug use. So here are the references. I actually found those 6 books actually great, and I copied a lot of stuff from them. If you have any questions, comments, or suggestions, contact this email.